Good evening, everyone, and welcome to the Genetics webinar this evening. This evening, we really have a very special guest and an academic who is well regarded the world over. I'd like to introduce to you Dr. Lieve Page-Christiaens, who is the Associate Director of Medical Affairs in Clinical Genomics at Illumina. Dr. Lieve Page-Christiaens works as a gynaecologist, fetal maternal medicine specialist, and associate professor at the University Hospital Utrecht in the Netherlands for 35 years. In addition to covering the whole field of obstetrics, she was also in charge of the prenatal screening and prenatal diagnosis program, as well as the Preimplantation Genetic Diagnosis program. She supervised 7 PhD theses, co-authored over 150 papers and over 40 book chapters, and was the main editor of the first book on NIPT, non-invasive prenatal testing, applied genomics in prenatal screening and diagnosis, published in September 2018. After reaching her retirement age at the University of Utrecht, she joined Illumina as an Associate Director of Medical Science and Clinical Genomics. And tonight we have her speaking to us. So please enjoy, and we can leave questions for the end. Welcome, Lieve, and please go ahead.
Thank you very much, Yvonne. It's a pleasure that I'm with you again, although I would much prefer to be with you face to face, as we have been 1.5 years ago. For the ones who don't know me, Yvonne has given the introduction of who I am, so I don't have to repeat that. I currently work at Illumina, and the equipment you see on the screen is what we call a sequencer, and that's the equipment used for many clinical applications where genome sequencing is important. NIPT is one of those, and the most recent one where it's been extremely relevant is the sequencing of the coronavirus. It's also used in cancer and in preimplantation genetic diagnosis. Besides developing equipment, Illumina also tries to develop end-to-end solutions, meaning tests that can be used to answer clinical questions such as prenatal screening for chromosome anomalies. I see there's a question to share my webcam, so I'm going to do that. Okay. There's the inevitable disclaimer that tells you that what I will discuss with you is my personal opinions and not necessarily the opinions of Illumina. For today, I have divided what I like to share with you in 4 sections. One is just to come up to speed, refreshing some of the basics. The second one is discussing the new guidances and national programs as to the implementation of NIPT. NIPT has, at its start, mainly been used as a contingent test, contingent to first trimester combined test, but these things are changing, and I will discuss the first results and publications and also the guidances. The third chapter, so to say, is about expanding the test menu. What does it mean? What can be detected and what cannot? And some illustrative cases to show what the clinical utility of looking wider than trisomy 13, 18, and 21 could be. And then at the end, I have my, I would almost say, my personal wish list. What do we know? What have we learned? And what would I like to achieve in future? We'll start with the basics. When maternal age was the only way to determine whether a woman was at elevated risk for having a baby with an extra chromosome, more than 10% of women were offered the option of invasive testing, which means that essentially with that screening strategy, 10% of the women had a false positive screening test result, their age. So when at a given point, first trimester combined test became available, and that was in the late part of the 20th century, that was a big, big step forward, because with the first trimester combined test, the false positive screening rate for maternal age could be reduced by half. It went from 10% to 5%. And when the false positive rate was set at 5%, we could detect in optimal situations 90% of pregnancies with Down syndrome. However, that still meant that 5% of pregnant women were confronted with an elevated risk result and had to think about the offer of invasive testing. And that is, to tell the least, suboptimal. 5% is a lot, and I do remember all these afternoons with consultations with anxious women who in the end didn't have anything, where it was all false alarm, and a waste of resources of all that consultation time in a university hospital. So when in 2011, exactly 10 years ago, NIPT became available for use in the clinic, that was an extreme step forward. And I would like to ask you to look again at these arrow figures: false negative 10%, false positive 5% with first trimester combined test. And if we flip to NIPT, we see false negative 0.3%, false positive almost 100 times lower than with first trimester combined test. And this slide and what's on it explains the enormous success of NIPT worldwide, as you all know. No genetic test has been implemented so rapidly as NIPT. It is the accomplishment of Mark Gill at the time in London and currently in Madrid to have done a lot of meta-analysis showing us the summaries of all these publications. I just heard a lecture by Tony Fauci just before before giving this presentation, and he talked about an infodemic, an epidemic of information. That also applies to NIPT. So we're always happy with people doing meta-analysis and systematic reviews like Mark Gill does. How did that become possible? It became possible because it was discovered by Dennis Lowe and his group, and also in the United States, that in blood during pregnancy, but also in blood of non-pregnant people like you and me, there is cell-free DNA in pregnant women from the mother and from the placenta, in non-pregnant people from the person himself or herself, and that is from fat tissue, hematopoietic tissues, and eventually benign or malignant tumors. And that's why cell-free DNA testing can be applied in many, many other situations, and not only in pregnancy. In pregnancy, there is 10 to 15% that comes from the placenta. If you take a blood sample not earlier than 10 weeks, and that is also the recommendation, not to go earlier than 10 weeks, because the concentration of the placental cell-free DNA could be too low below 10 weeks to give a reliable result. What is of course also extremely important is that the cell-free DNA of the placenta disappears very rapidly after birth. The half-life is 16 minutes, and we therefore look at the cell-free DNA of the pregnancy at hand and not of previous pregnancies. And that's not always the case for fetal cells. It is very important, as you know, to keep emphasizing that NIPT is a very, very good test, but it's still a screening test. And you've also seen that on my disclaimer slide. There's two reasons why it's still a screening test and therefore not diagnostic. One is that there's biological causes of discrepancies, and you see them summarized in this slide: mosaicism and vanishing twin. And two, there's also technical causes of discrepancies. In tests that don't do fetal fraction estimates, a too low fetal fraction that has remained unnoticed can be a cause or a reason for false negatives. In samples where there's a lot of maternal cell-free DNA because the mother has a certain disease, such as autoimmune diseases, the mother's cell-free DNA can be overwhelming and therefore, again, give rise to a false negative result. So it's important to always keep this in mind. That lets me transit to what we discussed during a pre-test consultation. And whilst it's very often said that it's help women make a choice, help women make a choice is the third panel or even the fourth panel of what happens during that consultation. The very first thing we should do during the consultation is check whether the woman in front of us can apply for NIPT, whether she's a good candidate. As I have already explained, there are some situations where she's not a good candidate, like if she has an immune disease or if she just has had a blood transfusion, for instance. So it's important to have a detailed information about her own history, about her pregnancy history, about her family history, and eventually, if she has had carrying testing, then the results of carrying testing. And the nicest example that I have from my own practice is a woman where the sex predicted by NIPT was different from the sex that we saw at ultrasound. And we had predicted a boy, and on ultrasound it was a girl. And when we confronted her with that information, she said, I may have forgotten to tell you that when I was a child, I had a bone marrow transplantation of my brother. Did that matter? So you can see that even with a good contact and good information, patients don't always tell everything because they think it's not relevant. And it's really important to make sure you know as much as possible. The second step in that pre-test counseling is an ultrasound. I always recommend to do an ultrasound prior to blood draw. And I know this is not always attainable, especially in countries where the distances to the hospitals are huge and where blood draws are sometimes done in local blood drawing points. So it's not always possible, but ideally it should be part of the consultation. Why? Because it could be a miscarriage, a non-viable pregnancy, and then you would probably not spend money on NIPT. Two, it's relevant to know whether it's a twin, and certainly relevant to know whether it's a vanishing twin eventually. And three, if there's already congenital anomalies visible, then NIPT is not the best offer, but an invasive test should be offered with karyotyping or microarray, whatever is available and applicable. Once these two steps are passed, then informing the patient about what an NIPT test can do for her and what it can't do for her is important. So she should be aware of the possibility of false positives and false negatives and the reasons for such discordant results. And she should also be informed that when the test is abnormal, that she should not jump to conclusions and certainly not take irreversible actions, but that a follow-up diagnostic test is the indication. She can decline to have such a test during pregnancy and postpone it till after delivery, but there's never certainty before the confirmatory test has been done. And finally,
sorry to interrupt you. Your sound is getting softer and softer. I don't know if perhaps you can speak up a little bit or move your microphone closer to your voice.
I will.
Sorry.
Yeah, it's fine. I'm happy you tell me. I'll speak a bit louder, and I am close to my microphone. Is that better?
Better, thank you.
Okay. What I can also do, I can also try to do my slap open. Wait a minute. Is this better? Is this better?
Much better. Much better, much better.
Okay, then I'll speak to my laptop. Okay, good. This is okay? Okay. So the last part of the consultation, I beg your pardon? Okay. The last part of the consultation is the last part of the conversation is then devoted to helping the couple make a value consistent informed choice. And with value consistent, we mean something that a decision that aligns with what they find important in this pregnancy, with children, and in life in general. Oh, now I have the problem, I can't move forward my screen. When the post-test counseling, the counseling when an abnormal result has been received, essentially starts with an ultrasound again, and that is because some anomalies might not have been detected early on in pregnancy and are detected when the result becomes available. It's very important for the guidance of the follow-up test to know whether there's ultrasound anomalies or not. There's a discussion that is not finished yet about whether CBS or aneurysm, which is the best follow-up test, but that very much depends, amongst others, on what we see on ultrasound. And I can point out that at the next ISPC meeting in June this year, there will be a debate between Fetal from Australia and Diana van Opstal from the Netherlands about the choice of follow-up tests, what is best, CBS or NIPT. And if the patient declines prenatal testing for a personal reason, then of course postnatal testing is a possibility as well. This helps me move to the
Lieve, we have lost you again.
I don't know very well what you're asking.
When we had you back, when you were talking to your laptop, it was much clearer. Now we cannot hear you at all.
I try it again, but yeah. I do it again. Yeah, but I have trouble moving my slides from here, so we'll see what happens now. NIPT as a primary test is pretty, I won't say pretty new, but is a strategy that has been advocated more and more in clinical practice. And what you see on this screen is a brief overview of the societies that have been stating already 7 years ago that NIPT as a primary test should be offered because of its superior sensitivity and specificity. The first society was the Belgian Society of Human Genetics, and a short while thereafter, they have introduced primary testing for all pregnancies. The second group was the group in the Netherlands. The Dutch Health Council advised NIPT as an initial test for Down syndrome, Patau syndrome, and Edwards syndrome. And that was followed last year by an advice of the American College of Obstetricians and Geneticists, who advised all the American obstetricians to indeed offer NIPT as a primary test. Another part of the implementation is the question about the test menu. And it is last year that as well the Dutch Health Council, as the French Association of Cytogeneticists, advised to expand the menu of NIPT and to also look at other autosomal aneuploidies. These were called incidental findings, and it's obvious that only when using a whole genome sequencing based technology you can see the anomalies in the other autosomes. It's not only the full chromosome trisomies or monosomies or the full arm duplications and deletions, but every duplication and deletion that is at least 7 megabase, and that is in essence the size of the anomaly that you can discern with a normal karyotype as well. So NIPT has reached the resolution of a karyotype that we used when maternal age was the indication for invasive testing. The key recommendations of the American College of Obstetricians and Gynaecologists was that NIPT is a screening option for all pregnant women, regardless of age or risk. That's because of the superior sensitivity and specificity. And of course, women have to make an informed choice. In addition, they also recommended to offer NIPT as a primary choice for twin pregnancies. And the reason for it is, again, that NIPT is very superior in twin pregnancies to the first trimester combined test. And invasive testing in twin pregnancies is much more risky than invasive testing in singleton pregnancies. The French societies had already recognized that years ago, and France was the first country to explicitly recommend NIPT for twin pregnancies from the very beginning of their national program. Another thing that the American Society of Obstetricians has stated is that tests that include fetal fraction estimations are to be preferred. And that's of course logic, because if you don't measure the fetal fraction, you don't know what it is, and you could easily give a falsely reassuring result in pregnancies where the fetal fraction is extremely low and therefore fetal DNA cannot be measured. That's especially tricky in pregnancies with small placentas, such as pregnancies with triploidy and trisomy 18. These have low fetal fractions and therefore could easily be missed if you don't measure the fetal fraction. To the test menu, the French Association of Cytogeneticists, more or less simultaneously with the Dutch Health Council, has in 2020 recommended to report clinically significant autosomal trisomies and eventually also monosomies. They have, for the time being, deferred to advise about CNVs because they first wanted to have time to collect all the literature evidence. And the Dutch Health Council did exactly the same. They advised whole genome sequencing based NIPT because it fits in the objective of prenatal screening to expand choices, to improve perinatal outcomes, and because also it is a future-proof technology that allows, with time and with increasing knowledge, to allow expansion of the test menu. They advised that in 2020, after a study that started in 2017, I had to come with the formal results, and I will talk about this as well. These policy statements and this support of government, but also reimbursement by insurers, allowed to do solid scientific research. And one of the publications that has generated very valuable data is the one that you see on the screen now in Genetics in Medicine this year by the Louvain group. Last author is Joris van der Mees, who you probably know of. And the study covered more than 150,000 NIPT tests done in 8 university-centered genetic laboratories. And these genetic laboratories do not only do the NIPTs, but they also analyze all prenatal and neonatal samples. So the follow-up of positive elevated risk NIPT results was very, very good because they did that in their own laboratories. More than 80% of the NIPT tests done in Belgium are done by the 8 university center laboratories, and the test is fully reimbursed. With those figures, the authors could also calculate that the uptake of prenatal screening in Belgium is almost 80%, 79%. First trimester combined test virtually disappeared, but mucotranslucency measurement remained as part of the first trimester anatomy scan. The results, screen positive rates were pretty much what was expected and fully aligned with what I will show with the results of the Dutch study. They also included twins, almost 3,000, and the results in twins were as reliable and even more reliable than the results in singletons. When you compare this with the Belgian data published by Van der Meij in 2019 in the American Journal of Human Genetics, you see that the screen positive rate in these overall populations is very, very similar, and the positive predictive value is also very, very similar, with the exception of trisomy 18. There's a bit of a difference there. We all know that trisomy 13 has a lower positive predictive value, and that is because trisomy 13 is more often mosaic and also more often mosaic only in the placenta. So that is the explanation. The impact of introducing NIPT as a primary test in Belgium was considerable. Whereas in 2013, there was more than 6,000 invasive procedures, half of them for maternal age or abnormal first trimester combined test. In 2018, the first year where the primary NIPT was fully implemented, it was 2,500, so a reduction of over 50%. And the remaining indications were ultrasound anomalies, patient history, or the risk for congenital infections. And of course, abnormal NIPT tests. Also, parallel to this, the live birth incidence of babies with Down syndrome decreased from 1 in 1,600 to 1 in 2,500. Also published this year was the data on what happened with the uptake of screening in a country where NIPT as a primary test is introduced. There was a fear that after the introduction of primary NIPT, there was going to be a massive increase of the use of that technology, and the fear was mainly a financial concern. But what we saw in the Netherlands was there was an increase, but it was moderate. It was a 10% increase of utilization of prenatal screening after the introduction of NIPT as a primary test. That is the second red arrow, the red arrow on the right-hand side. The red arrow on the left-hand side shows what happened after NIPT was introduced as a secondary test, and there you see only a moderate uptake, increase of uptake of prenatal screening. You will notice that in the Netherlands, the uptake of prenatal screening is a lot lower than in Belgium, where it was 80%. And reflecting on the causes, I think two things play a role. The fact that in the Netherlands, there's a co-payment of 175 euros, in my perception, plays an important role, and I will show you some evidence in the next slide. But there's also a huge cultural difference between the Belgian population and the Dutch population. The Dutch population is much more inclined to want to take their own decisions. They weigh different opinions and get their information in different places. Whereas the Belgian population, on average, you can never standardize, has more a culture of what the doctor says is good, and I'll do what is available. So there's more compliance to the general guidance that they get from doctors. But reimbursement probably is a very important factor, and this slide shows what happened in 2015 in the Netherlands when women above 36 years of age all of a sudden had to pay for prenatal screening. It had been free for decades. Invasive testing had been free when maternal age was the differentiator. And like as a tradition, first trimester combined test was also free for women over 36 years. And that changed in 2015. And we saw a decline in uptake of 12% more or less by women over 36 years. And I think this is a slide, but there's other data around too that shows the effect of reimbursement on uptake. When offered a choice, almost 80% of women choose to have expanded NIPT over standard NIPT. This brings me to the third part of the things that I want to share with you, and that is about expanding the menu of NIPT. I'll give you a brief overview of what that can bring us, and also show some examples as an illustration of the clinical utility expansion of the menu can have. First of all, what happens to the screen positive rate? And you don't have to read the whole slide. What happens to the screen positive rate is an increase of 0.44%. In majority due to an increase of abnormal NIPT results for rare trisomies, and a minority 0.1% because of partial deletions and duplications larger than 7 megabase. And when you look at the figures at the bottom line, you'll see that the 0.44% is more or less the same as the screen positive rate for sex chromosome anomalies, and that is something that we have been offering for many years. So the increase in screen positive rate will be modest, and therefore it's not gonna increase tremendously the number of patients offered invasive testing if we expand the test menu. What is the clinical usefulness? What I have done, and this is a slide I used for the debate I had with Sylvie Langlois last year at ISPD, I collected and read and summarized all the articles about positive predictive value of the first trimester combined test and positive predictive value of NIPT, expanded NIPT for that matter, for different chromosome anomalies. Trisomy 21, rare aneuploidies, copy number variations, sex chromosome anomalies, and selected microdeletions and duplications. And you can see on this slide that for all these conditions, NIPT is superior to first trimester combined test. That's not a big deal. That's not big news. We all knew this. But what is also the case is that rare autosomal aneuploidies, even if not confirmed in the fetus and confined to the placenta, can have clinical significance in that they affect fetal growth, they are related to miscarriage, or even related to fetal anomalies whilst you cannot find the trisomy in the fetus. And therefore, the positive predictive value of NIPT for other placental pathology is again much larger than for first trimester serum tests of all sorts, not only a PAP-A, but also PLGF together with maternal factors like uterine artery Doppler and maternal mean arterial blood pressure, the Gynaecologist algorithm. All these strategies have a lower positive predictive value for adverse pregnancy outcome than NIPT. Some cases. The first case comes from, it's all published cases. The first case comes from the Trident study, has been published by Van Opstal, and is, as a matter of fact, because it was the Trident 1 study, a case of a contingent NIPT, contingent to an abnormal first trimester combined test. At that time, we performed NIPT without the possibility to do a fetal fraction measurement. It was so-called lab-developed test. The other tests, the commercially provided tests, were really upcoming and not widely available yet at that time in the Netherlands. So we had a lab-developed test. The NIPT result indicated an increased risk of trisomy 9. Because this was new for everyone, the patient declined amniocentesis and chose to have an ultrasound. And on ultrasound, we saw an echogenic focus in the heart, which is considered a marker, but also at 20 weeks growth restriction. And as you all know, as obstetricians, growth restriction is at that gestational age is an alarm sign and should maybe even be considered a congenital anomaly. The baby that was born at 37 weeks was extremely small, 1800 grams, and in cord blood, karyotype, and fish, a low-grade mosaicism for trisomy 9 was detected. Initially, of course, everyone was sort of reassured because it was such a low-grade mosaicism and there was no anomalies other than the growth restriction in the baby. But as the baby developed, it became more and more clear that the development was delayed. It remained tube feeding dependent. The growth didn't progress very well. It had craniostenosis and it was dependent on oxygen. Mosaic trisomy 9, indeed, when you look in the literature, comes with a high risk for abnormalities, cardiac, renal, brain, eyes, and the risk for functional abnormality cannot be seen at ultrasound and even not at birth. Trisomy 9 is not the most frequent rare autosomal trisomy, but it is not extremely rare, and it's considered with trisomy 8, 9, 16, 20, 22, 15, one of the rare trisomies that come with a clinical phenotype, and that is worth reporting according to the French cytogeneticists and also the Dutch program. The second case example I want to show you is a trisomy 15, also published by Mark Purtell. And here it was a primary NIPT test. Fetal fraction was done 6.8%, which is adequate. Ultrasound was normal, and because trisomy 15 is an imprinted chromosome, the advice was to do a SNP array, and as you know, SNP arrays allow to look for uniparental disomy, and that was also what has been found, uniparental maternal disomy coming with the Prader-Willi syndrome. And uniparental disomy is very often the result of trisomy rescue, so the conceptus is trisomic, and then one of the extra chromosomes is picked out in the very early embryo, and if the wrong one is picked out, the chance is 1 in 3, then the baby remains with 2 chromosomes 15 of its mother or 2 of its father eventually, but more often the mother, and that leads to a clinical phenotype. Prader-Willi syndrome is characterized by a rapid development of obesity after birth. Most children have diminished IQ, there's behavioral problems, and there is infertility. And my last case example is about a partial deletion. This patient had a targeted test. I don't recall which one it was, but a targeted test, and that gave normal results. Fetal fraction was adequate, over 10%. Ultrasound showed fetal ascites, and all obstetricians that are currently listening to me know that can be a sign of blood group sensitization, but no blood group antibodies could be found. Can also be a sign of parvovirus infection, but that was also negative. And an amniocentesis was planned, and a 12 megabase deletion of chromosome 5 associated with Cree-Duchat syndrome was detected. Cree-Duchat syndrome comes with developmental delay. The clinical severity aligns with the deletion size, but not exactly. And the breakpoints vary, so you cannot identify all Cree-Duchat syndromes via NIPT, but anyone larger than 7 megabase is detectable. And this brings me to the end of my presentation and my so-called wish list. What have we learned, and where do we go? Where do we go from here? What we have learned that for the prognosis of a chromosome anomaly, there's a multitude of things that are important. The chromosome involved, the biparental inheritance, the timing, and I didn't talk a lot about it, but the timing of the non-disjunction, if a non-disjunction is in meiosis 1, it is likely to be much more relevant for the phenotype than if it is post-zygotic in one of the mitoses. That is going to influence the degree of mosaicism. And although, again, the degree of mosaicism is not linearly correlated with the phenotype, it does play a role in the severity of the phenotype. In CNVs, the size of the CNV and the amount of material gained or lost, and also the gene density in the material gained or lost. And we're all very happy with websites like ObGyn and Gene Review, where we can rapidly look at CNVs and their clinical phenotypes, and every geneticist involved uses these sources of reference a lot. Gaps of knowledge and what's to do in the future. I think it's very important that all together we try to gather data on the clinical utility of information on rare autosomal aneuploidies and large copy number variations. Hand in hand with that, the development of best practices for follow-up, and I can make you happy by saying that some are on their way, because they will be a requirement for the Dutch national program. The third one is, and I refer to that, is how to measure mosaicism via NIPT and how to relate the degree of mosaicism to the counseling and to the expected phenotype. And last but not least, most of all needed an accessible database with NIPT results and their outcomes. We have databases like Decipher and ClinVar for born people, and I would very much like to have a database for NIPT results and their outcomes. And with that, I will close and open up for questions you may have.
Well, thank you very much, Lieve, for that presentation. I have a few questions coming through. Okay, so if I can ask, the first question is, so then what is the place of nuchal translucency measurement after the introduction of NIPT? I know you spoke about ultrasound, but the NT measurement, I presume, still quite relevant and should be used in conjunction with NIPT?
I would say that there's no place for only a nuchal translucency measurement. I think if we do a nuchal translucency measurement, we should also aim for documenting some other things of the fetus. And it depends, of course, on the gestational age. You can do a nuchal translucency measurement between 11.5 and 13.5 weeks. And depending on whether you're closer to 11 or closer to 13, you can also reliably look at other things. But things that you always should see is acrania and encephaly, holoprosencephaly, a abdominal wall defect, an obstructed bladder. I think those are the 4 things that you should be able to see very well. So just doing the nuchal translucency is I think, incomplete. I won't say insufficient, but it's incomplete. And as pregnancy progresses, you can even see more things. An important question is, do we do NIPT first and then the first trimester anatomy scan, or do we wait with NIPT till the first trimester anatomy scan can be done? And although I do see the rationale of doing the first anatomy scan first, I think it's a pity to delay all the NIPTs potentially till 13.5 weeks, because you will then end up in the early second trimester when the result is there and lose the opportunity for a CVS at 11 weeks and eventually a quick result for the patient. It's a trade-off, and maybe we'll have to individualize that per country or individualize that per patient. In some countries, patients come very early and you can have a conversation, do a vitality ultrasound and take blood at 10 weeks and have the result at 10.5 weeks, depending on technology. And in other countries or with other patients, patients will come at 14, 15 weeks. And then, of course, it's too late for a nuchal translucency. But if they come at 12.5, 13.5, then I would first do the anatomy scan and then the NIPT thereafter. So there's not really a rule, but there is absolutely ultrasound and NIPT go hand in hand. And I hope I've shown that in my slides as well. One cannot do without the other.
Thank you. Thank you very much for answering that. And then obviously moving on from there is there a role for first trimester combined screening alongside NIPT, or many doctors have asked, can NIPT replace this first trimester combined screening?
Yeah, there's two two answers to that. I know there is countries, but maybe not too many, that use what I call the Nicolaides algorithm for predicting early preeclampsia. And the Nicolaides algorithm is PLGF, PAPE, mean arterial blood pressure of the woman, and uterine artery Doppler. That is currently the best algorithm to predict preeclampsia, early preeclampsia, so preeclampsia before 32 weeks. That is not the same as first trimester combined test. It doesn't contain ACG, for instance. There is a place for prediction of early preeclampsia in women who have never been pregnant before. In women who have been pregnant before, the outcome of the first pregnancy is the very best predictor of whether she will have a preeclampsia or not. So only for nulliparous women and in centers that do the full algorithm, so not just part of it, there would be a place for PLGF and PAPE, but not in the other centers. First trimester combined test for Down syndrome screening, if primary NIPT is available, could only have a function as a reflex test. If your NIPT test fails, then, and you have a tube of blood in the freezer, or you have serum, then you could do first trimester combined test as a reflex test. But knowing that all the failure rates of all tests are coming down, and the failure rates of a whole genome sequencing based NIPT test is like 0.7, and in some laboratories below 0.5%, I think it's not really worth it to have a reflex tube of blood for first trimester combined test, especially given the fact that if you repeat the failed NIPT test, the majority of them will be successful, except for the low fetal fraction. The very low fetal fraction, as I indicated, have an increased frequency of trisomy 18 and diploidy, and if there's a low fetal fraction and a failed NIPT, it's probably best to offer invasive testing. So in summary, for nulliparous women, in centers that offer the algorithm for early preeclampsia, there's a place for PLGF and PAPE. There's, I think, no place for FCT as a reflex test.
Thank you, Lieve. And I have one last question. And that is, if a rare autosomal aneuploidy is detected, what should the clinical follow-up be if the result is not confirmed with an invasive test? So if you've done an amnio and the amnio doesn't show this rare autosomal aneuploidy that the NIPT showed, what are the next steps?
Yeah. That's a very, very good question. It's actually been shown in small studies that if NIPT clearly indicates a rare trisomy, not a borderline case, but a clearly elevated score, and you don't find it back in amniotic fluid, but you look at the placenta at birth, that you always find it back. But on the condition that you look at more than one biopsy, because it doesn't have to be in the whole placenta, it's sometimes only in part of the placenta. So if you have an unconfirmed rare trisomy, unconfirmed in amniotic fluid, and you look at 4 biopsies in the placenta, you always find it back. And that means that abnormal NIPT results for rare trisomies are biologically true positives and not false positives. The next question is, of course, what does that do with the placental function? And I showed you that rather crowded slide from Peter Ben, who has published it in I think, ultrasound of obstetrics and gynecology together with Francesca Gratti, and he has looked at the outcomes of pregnancies with rare trisomies described in six publications, and amongst others, Purta and Chaperon and Van Opstal, so from different countries, Australia, France, the Netherlands. And he has seen that only in around 40% of these pregnancies, the outcome was normal. In the other ones, it was either a baby with a congenital anomaly, even if it was only the placenta that was affected. We call that cryptic mosaicism. These babies have the abnormal cell line somewhere in their body, only we haven't seen it in amniotic fluid and we haven't seen it in newborn blood, but it's somewhere in there and it causes anomalies. The other adverse outcome, and that has been known for decades by a study by a group in Canada, is fetal growth restriction. So the protocol should be to monitor fetal growth more accurately, more frequently than an average pregnancy. Preterm birth is a complication that is almost always present with trisomy 16, confined placental mosaicism. And there's, of course, the miscarriage and the fetal loss to stillbirth. So a placenta with an extra chromosome is not a normal placenta, and these pregnancies need to be followed up. I hope this answers your question.
Thank you so much for your Debbie, do we have any more questions? I have not received any more. Sorry, Lieve, there's just one more.
No, Yvonne, we don't have any additional questions.
Okay.
Okay. Can I just ask one more about NIPT for multiple pregnancies? Are they useful? Can they be used? And in which instances should they not be used?
I think they should be used in all multiple pregnancies. There's very good evidence by meta-analysis, again, the group of McGill. The first author is now Judah, G-U-D-A-H, Ultrasound in Obstetrics and Gynecology. That is a very recent meta-analysis of cell-free DNA testing in twins. For those of you who attend to the FMF webinars on Sunday, and they're also available online on the FMF website, the last Sunday's meeting has been almost entirely devoted to twins, and cell-free DNA in twins has been discussed. It's as reliable in twins as in singleton. And as said, first trimester combined test is less reliable than NIPT, but also invasive testing is more dangerous in twins. There's even a recent publication from Italy. First author is Laverde, and he described a couple of triplets where they have done NIPT. Their fetal fraction threshold is higher. They put the fetal fraction threshold higher. There was one affected pregnancy with a trisomy 21 in one of the 3 babies, and they detected it correctly. A more difficult question maybe is the vanishing twin. Should you allow for NIPT in the vanishing twin? The vanishing twin has a 50% chance of having a chromosome anomaly, and that cell-free DNA, if that vanishing twin is still in utero, can remain in the mother's circulation for many, many weeks. So you incur a risk of a false positive result. And if you discuss that with the woman, and especially with the laboratory really has to know, then maybe you can do an NIPT in a pregnancy with a vanishing twin. And if the result is normal, then you know it's okay. I have never read about a false negative result with vanishing twins, but I have read about a false positive result with vanishing twins. So depending on the individual situation of the woman, I would not make a firm statement that you cannot do NIPT in vanishing twin pregnancies, as long as the laboratory knows and as long as the couple is well informed about the increased risk of false positive results. Also, I don't know, but maybe some in the audience know, whether invasive testing in a pregnancy with vanishing twins maybe could have higher risks than invasive testing in singletons because of the necrotic material that is in the uterus. Maybe there's an elevated risk for rupture of membranes, for instance. I have no evidence, but it's a thought that I want to share with you. And at the end, I want to say it's a pity the sound was not good at the beginning. I don't know, but I'm happy we solved it for the second half of the lecture. And if needed, I can do a new recording that you can make available for the audience. I'm very grateful for people who have spent their time with us tonight.
Fabulous. Thank you, Lieve. I mean, your talk was excellent and certainly gave us a lot to think about. And thank you very much for answering all these questions. They are often questions that have come up. And we certainly appreciate your guidance and your advice on that. So thank you very much for presenting this evening, and thank you for answering all our questions. And we have managed to certainly fill the whole hour with some stimulating discussion. So thank you, and it was lovely to have you with us, and keep well.
Yeah, stay healthy, stay safe, and all goods to you.
Thank you. Thank you, everyone, and good night. And please feel free to contact us should you have any further questions, and a recording of this webinar will be available. Thank you all.